Thank you, Ali.
All right. Um, Hello, everyone. We are excited to start this pre-Congress webinar for the World Congress of Bronchology and Interventional Pulmonology, which will be happening in Melbourne, Australia in December. This webinar is meant to give some updates on the pleural disease, lung nodules, and intratumoral through bronchoscopy interventions, and emphysema and COPD updates. We have outstanding speakers. We are so honored they accepted to give their talk and their insight for the audience here. We're also excited to hear that about 400 audience has registered for this webinar, and I want everyone to wish them a good time across the globe. Might be different time for everybody. Thank you for people who get up early or they're late at work, and then they also joined us here. We have speakers from UK, United States, and Australia. And then also we would like to thank the sponsors who agreed and shared and sponsorship for this webinar, including BD and Lead Optic from the United States. Also another announcement that we have for late-breaking abstract submission, which is ready for the Congress. So people who have outstanding results in their research or other announcement, they would like, we invite them to share their abstract. The links are provided here. Without further ado, I would like to introduce our first speaker, Dr. Nick Maskell. He is a world well-known expert in the interventional pulmonology, and he is going to talk about updates in pleural disease, pleural effusion. He's a professor at University of Bristol. I would like him to take the stage. Nick, thank you for agreeing to speak for us. I will stop sharing, and then we can have your slide ready for you to present.
Lovely. Thank you very much for the warm welcome, Ali, and hello, everyone. I'm delighted to be here talking about pleural medicine, and I've been asked to highlight some of the upcoming great seminars that we're going to hear at the WCBIP in Melbourne. And I'm also going to give an overview of where we are in pleural disease in 2026. Next slide, please. I think hopefully in the next 20 minutes or so, I'm going to just highlight perhaps the importance and also the limitations of national guidelines that we all use. And unfortunately, by the very nature of guidelines, as soon as they're published, they're outdated, and RCTs come along. And so I'm going to highlight some RCTs and the results for some of those that missed the last BTS deadline for the latest guidelines, but also tantalize you with some of the great RCTs that have finished, and the results are going to be presented for the first time in Melbourne in 2026, making this meeting an absolute must. And also highlight the numerous areas where there's no evidence base, and if that's the case, we have to rely on expert opinion. And how do we get that? And some of the seminars that we're going to hear in Melbourne are going to address some of those difficult areas where we reach for the guidelines and find that there's no consensus on how we should manage these cases. Next slide, please. So I think we all probably have read these guidelines. They're in 2023. But interestingly, I've been involved in guideline preparation for a couple of decades now, and the methodology has changed. And certainly the first iterations of the BTS guidelines, we covered the whole spectrum of pleural medicine. And now using grade methodology, we're no longer able to look at a very wide scope and have to focus on individual PICO questions, which of course is very good at actually delving into the evidence of those particular PICO questions, but doesn't give you an overview on how to manage the whole of pleural medicine. Next slide, please. So I think that there are some really good positives about the guidelines. They've been downloaded many, many times, and they certainly are good for the non-expert to get a quick overview of best practice. I think they're increasingly patient-centered, and they do highlight where we need further research. But as I said before, they're outdated before publication, and they only cover isolated PICO questions now. So we need more than them. Next slide, please. This is just really an example from the last guidelines of really where we were only able to choose very limited 5 maximum PICO questions for each topic area, meaning that there's lots and lots of areas that we weren't able to delve into in those guidelines, which is definitely a weakness of them. Next slide, please. But I think that we've been lucky in pleural medicine. I think it's come a long way in the last 20 years, and we now have lots and lots of RCT data in order to actually improve the evidence base of the way we treat people with pleural disease. This is just an example of all of the RCTs that have been published in the last 15 years or so in malignant pleural effusions. And you can see on the left-hand screen there's at least 12 good quality RCTs that have been published in very good journals that help guide the best way to manage malignant pleural effusions in patients. Next slide, please. These are just a couple of examples of things that didn't make the guideline that have been published. Just so that you know, as I go through the talk, if there's a recently published paper, I tend to have put sort of a fire somewhere on the slide to show that it's a hot topic. If there's 2 fires, then that's a very hot topic, and that's something that's going to be discussed in Melbourne. And if there's a little symbol that says expert opinion, you know the evidence base for this is quite poor. So this is the first study I just wanted to put in focus. It was published in the ERJ, but after the guidelines, and it was looking at people predominantly with mesothelioma where their first biopsy had been non-diagnostic, but the MDT felt that there was a malignant process going on from the CT scan. And these patients were asked to participate in a trial where half of them got a second biopsy, which is a CT-guided biopsy after a PET, and the PET was used to target where that biopsy was taken from, and the other half just got a CT-guided biopsy. And interestingly, and perhaps unexpectedly, there wasn't really a big increase in the yield at all when actually targeting where you actually biopsied it. And the CTs seemed to be perfectly adequate for that. Where it did have some additional value was where there was extrathoracic disease, and sometimes there was a better place to biopsy than the pleura, particularly if it was just mediastinal pleura where the predominant problem was. So this study really tells us that there's no routine necessity to get a PET scan on the second biopsy in order to target it, but sometimes it's useful when you're looking for an extra site to biopsy. Next slide, please. This next study that missed the guidelines, the Optimum study, this is a study really looking at people with a malignant pleural effusion coming into hospital and having a chest drain and talc pleurodesis, a slurry on the ward, versus having an indwelling pleural catheter placed as an outpatient and then having talc placed down that catheter a week or 2 after that primary intervention to see whether there was any difference in the very important patient-centered quality of life outcome over the next 30 days. And this study showed that there was no difference in those 2 techniques, showing that really they both had similar efficacy when looking at patient-centered outcomes. Next slide, please. So let's go on to talk about something that is going to be presented in Melbourne. This is the TACTIC study, which is a study that Alex Dipper was the first author in my institute for, and are presenting this study in Melbourne. It has recently been accepted for publication in Lancet Respiratory, but only in the last month or so. And this was looking at patients that basically had a malignant pleural effusion that needed to have some management done for them, and that 10 centres in the UK took part, and the patients were randomised to either having a thoracoscopy and 4 grams of talc as a poudrage, and then an indwelling pleural catheter placed, and with the emphasis on trying to discharge them early with regular drainages, versus the standard procedure, which was thoracoscopy and 4 grams of talc as a poudrage, and then a standard drain, and then standard care. And the primary outcome was hospital bed days. Next slide, please. We were pleased that this study managed to recruit a little bit behind schedule because of COVID, but it managed to complete to target number, and we had 62 in each arm, and the patients were well balanced. Next slide, please. Interestingly, the primary outcome surprised us, and when we saw these results, we were certainly it wasn't what we were expecting, which was that really there was no difference in the time in hospital that was spent between patients that actually had the indwelling pleural catheter placed and those that had the standard thoracoscopy. I think there's going to be some insights that I'll describe as to why I think that was the case when I give my talk in Melbourne. But just a very brief summary of why I think that was the case. I think that a lot of centres that took part in this study weren't used to putting an IPC in at the end of thoracoscopy and felt nervous about this additional procedure and therefore were keeping patients in hospital slightly longer than they would normally do. And then on the flip side, with the thoracoscopy arm, because they were very used to managing these, they tended to take the drain out earlier. And so I think that that's probably one of the reasons why the primary outcome showed no difference. But the most important take-home message here, I think, is that patients that actually had an IPC placed didn't need to have another pleural procedure. It was safe, it didn't cause more pain, there wasn't more loculation. And so it certainly seems to be an additional thing that you can do if you're centered around getting the patient out of hospital and they really don't want to come back for a further procedure if a standard thoracoscopy and TAUC failed. Next slide, please. So in Melbourne, we're going to be talking a little bit about difficult cases. And one area where there really is very little evidence is how we manage trapped lung. I think we all know that actually trapped lung is probably more common than we think. And studies recently have shown that it can be up to about 25% of patients with malignant pleural effusions. They tend to have a poor outcome. They tend to have more advanced disease, and manage them is difficult. And I think that the most important thing here is that if they're asymptomatic or they've got minimal symptoms, I would try and leave these well alone. If they are symptomatic, we have to prove that the pleural fluid and draining them actually does alleviate their breathlessness, because there are other causes of breathlessness, as you know. And so we would always tend to do a therapeutic aspiration first to make sure the patient would benefit. I think that indwelling pleural catheters are a good option for these if they're symptomatic and they benefit from a therapeutic aspiration. But the most important thing here is not to overdrain these patients. Next slide, please. Another area that I find particularly difficult is how to manage the heavily loculated malignant pleural effusion. And I think there's very little data to show that there is definite benefit of giving fibrinolytics in this setting to try and break down the locules. Whenever we've done it in our centre via an indwelling pleural catheter, it seems to work well for about 7 to 10 days, and then the patient becomes heavily loculated again. I think there is a surgical option here for patients that are of good performance status, but a lot of the patients that we will all see in our practice are not necessarily fit for surgical intervention. So another area that needs better research, in my opinion. Next slide, please. So this is a really exciting study, AMPLE-3, that basically has now finished recruiting and the results have been analysed. It's currently in submission with either the New England Journal or JAMA, so a high impact factor. And Deirdre Fitzgerald and Gary Lee are the authors of this study. The primary research question here was comparing indwelling pleural catheters with actually a surgical intervention with VATS and a VATS pleurodesis or decortication in people with a malignant symptomatic pleural effusion, but people that actually were anticipated to have a good survival. Next slide, please. So there hasn't been very many surgical studies in malignant pleural effusion. The last one was meso-VATS, where we were comparing TAUC slurry with TAUC with surgical VATS, and that showed no advantage. We know that around the world, IPCs are now much more widely used, especially in those with trapped lung. And most of the malignant pleural effusion trials that I showed on a previous slide only really collect data for 3 or at maximum 6 months. AMPLE-3 has actually followed everyone up for 12 months. It was interesting that a recent published survey in Australasia of what clinicians felt was the best management for a malignant pleural effusions with fully expandable lung and a longer prognosis was very split, with a third feeling IPC was the way forward, a third feeling that you should refer for surgery VATS, and a third saying talc slurry. And so this is an ideal bit of equipoise here in order to conduct this study. Next slide, please. So this is the trial criteria. You needed to have a symptomatic malignant pleural effusion to get in and a predicted survival of greater than 6 months and a good performance status. And you can see the exclusion criteria there that are pretty standardized on the right-hand side that I won't go through. The primary outcome for this study was the need for a further pleural intervention for management of the pleural effusion within the 12-month period following randomization. And patients were randomized in a one-to-one fashion between an optimized IPC protocol, which include regular drainages and talc slurry installation via the IPC if appropriate, versus a surgical VATS pleurodesis, where the surgeon had free range of what to do when they were in there. So some would have had a decortication, some would have had a talc poudrage, and breakdown of adhesions. All of these patients, as I said, were followed up for 12 months and they were very well minimized by those criteria, including whether they had trapped lung or not. Next slide, please. So you can see that the sites were involved were across the globe, which is great. So a real sort of international study. And I'm sure the authors are very grateful to all of those centres for helping get this study completed. Next slide, please. You can see that this is great recruitment really for a surgery study, and I really must take my hat off to Gary Lee, who led this research in managing to get this study completed. It's very, very difficult to get a surgical study completed when some of the surgical centres felt there wasn't equipoise. So big kudos to him and his team for that. Next slide, please. So just to finish off on AMPLE-3, the results are not published yet, and they're going to be presented by Deirdre for the first time in Melbourne. So it will be great to see these slides and the results at that meeting. In the same session, we're also going to have Ken Chan, who's one of the authors of this excellent paper that's recently been published in the New England Journal of Evidence, that really gives us hope for a new way of testing pleural fluid to see whether it's due to TB or not. Next slide, please. I think that we're all aware that basically the diagnosis of tuberculous pleuritis is difficult. This is because of the paucibacterial nature of TB and also often the presence of NTB. And this study is very impressive because it managed to cut down the NTB signal in pleural fluid by using DNA sequencing and alignment of targeted regions in the microbacterial genome that were unique for TB. And once they actually did that, they managed to get a very impressive under the curve of 0.99 to differentiate TB pleuritis from non-TB pleuritis with very, very high sensitivities and specificities. This study was conducted in Hong Kong with sort of a medium incidence of TB. Next slide, please. They actually took over 1,200 patients with a clinical diagnosis of pleural effusion, and a number of those were excluded for the reasons laid out in that slide. And then of the 400 that met the eligibility criteria, they were all tested and then followed up to get a final clinical diagnosis. Next slide, please. This slide really just shows the excellent ROC of the pleural fluid in using this test. And I think that this will be really useful for us in the future. And it's great that we've got one of the senior authors coming to present this data in Melbourne and to tell us more about its role in guidelines and investigating people with TB in both low, medium, and high TB settings. Next slide, please. I put this slide in because it's recently been published, and there's very little in pleural medicine at the moment on frailty. And this is one of the first papers looking at frailty and its association with secondary pneumothorax. And we can see here that we used a big sale data bank, and all of them had got a electronic frailty index that had been recorded, and it identified 3,500 individuals that have been diagnosed with secondary spontaneous pneumothorax over a 20-year period. And it showed that really, depending on whether they were mildly frail, moderately frail, or severely frail, the hazard ratio was very much higher for dying after your secondary pneumothorax in the subsequent year if you actually had severe frailty. So you can see here that severe frailty meant that over 55% of people had died within 12 months. And that's perhaps something that we don't recognize when we actually are managing these people at presentation in hospital, just what a high mortality secondary spontaneous pneumothorax has. Next slide, please. So this paper has been recently accepted for publication in the ERJ, but it's not out yet, but it will be probably within the next 6 weeks. And Steve Walker is coming over to Melbourne to present this work of this RCT, looking at whether needle aspiration versus chest drain as first-line management for secondary spontaneous pneumothorax is worthwhile. This is a pragmatic, multi-center, non-inferiority trial that took place in the UK across 15 sites and had 110 participants that were randomized in a one-to-one fashion between simple aspiration versus chest tube drainage as the initial management. Patients that had simple aspiration were kept in hospital under observation, and the primary outcome was the length of stay in the first 30 days. And a number of patient-centered outcomes are also recorded. Next slide, please. In order to get into the study, you had to have a pneumothorax of sufficient size and symptoms for the treating physician to want to intervene with some sort of intervention. And the patient also had to have a secondary spontaneous pneumothorax with underlying lung disease greater than the age of 50 with a significant smoking history, or suspected underlying lung disease with a CT scan that then confirmed that. Next slide, please. The demographics were really quite well balanced. The mean age of the patients was about 65, and the majority of them were male, as you would expect. Next slide, please. You can see here that the primary outcome of this study showed that basically it was both that needle aspiration was both superior to the length of stay for intercostal chest drain when looking at the primary outcome, which was length of initial hospital stay. So those that had a needle aspiration had an average stay of 4.8 days. Those that had intercostal chest drainage were 9.7 days. So that looks very positive, but there's more to this. Next slide, please. Because when we actually looked at the number of people that got readmitted over the first month and the total length of hospital stay over that first 1 month period, you can see that that strong signal is reduced, with the needle aspiration group now being 7.3 days versus 10.3 days, and is no longer statistically significant. And that was because a number of people with needle aspiration came back in and needed a further intervention. The implications of this study will be discussed by Steve, and how he feels that this paper fits in with his day-to-day management of people with secondary spontaneous pneumothorax. Next slide, please. So I think that I've already said that although initially the initial length of stay was much reduced with needle aspiration, up to 70% required a previous, a further admission. And that therefore meant that a lot of them had a further pleural procedure. But interestingly, in the arm that actually had chest drainage initially, many of those needed a second drain during their admission. Next slide, please. So this is my final slide, really just saying that we're going to have a discussion in Melbourne about the role of blood patch. This is another area where the evidence base is not great, but there are some RCTs that are actually carrying on at the moment in the UK, looking to try and improve the evidence base of this particular procedure and comparing them with endobronchial valves. So I think hopefully in the last sort of 22 minutes or so, I've just given you an overview of where pleural medicine is in 2026. It's an exciting area. We've got lots of big RCTs that are coming out that are improving our evidence base. And I look forward to seeing you in Melbourne so that we can share some of the results of those studies that you haven't seen today for the first time. And I hope that you come and have an enjoyable meeting. Thanks for your attention.
Thank you, Dr. Maskell. Really, you nailed it in this short time, a broad review of clinical trials, a lot of studies that is ongoing and ready to be published. Definitely is a very extensive disease, complex disease, and a lot to learn, and is nicely show that how much we need to learn as a good opportunity for people to come to Congress in Melbourne and learn more. Definitely a lot to learn. Thank you again for your time. I know it's very late for you in UK, but as a quick housekeeping, the audience can type their question in the QA, and we'll at the end of the talk we will present the questions, and if we can reach to all of them, if not, we can address them later on to the speaker so they can get back to you. Without further ado, we're going to move on to the next topic, and I would like to introduce Dr. Sterman, a great leader in bronchoscopic intratumoral therapies with a vast experience and expertise in this area. We can't wait to hear your talk, Dan. The stage is yours. Please go ahead.
Let me make sure, Ali, that I have the correct one. Can everyone see my screen?
Yes.
Great, thank you. And thank you so much for the honor of being one of the three speakers here today with my two colleagues, Nick Maskell and Alvin Ing. And thank you, Ali Sadougi, as well as Danae Kamuzan, for the invitation. My goal is a little bit different than what you just heard. My goal is to give you a sort of a very quick, broad overview of this field and then take you down the path of one such intratumoral therapy, which is now in a global phase 3 randomized controlled trial, which I believe is a huge advance for this field. And I will be talking about these areas in Melbourne, about a variety of different approaches, but also trying to recruit individuals to become investigators for this landmark clinical trial that I think can change the way that we treat some individuals with lung cancer using bronchoscopic therapies. So this is my disclosures, nothing specifically relevant to this talk. I am the co-global principal investigator of these trials for Candel Therapeutics, but I do not get any financial support for this role whatsoever. So 25 years ago, I published a paper with my first interventional pulmonary fellow, now in Madrid, Spain, Luis Cerro, and we published this in the New England Journal of Medicine. And we thought we had a very broad overview of interventional pulmonology at this time, which consisted of a variety of interventions, primarily for palliation, therapeutic flexible and rigid bronchoscopy, endoluminal tumor debulking, airway stenting, pleuroscopy and other pleural procedures, and percutaneous tracheotomy and other ICU-related procedures. And when we think about the last 25 years in interventional pulmonology, specifically on the bronchoscopic side, where have we advanced? We've primarily developed advanced diagnostic bronchoscopy, both linear and radial endobronchial ultrasound, and electromagnetic navigational bronchoscopy, now robotic bronchoscopy. And we've advanced in bronchoscopic treatments for non-malignant diseases, which we'll hear about from Professor Ing shortly. But I would argue that where we're headed in the next 25 years is going to be the definitive treatment of lung cancer and other malignancies of the thorax using endoscopic approaches. And that's what I will be talking about in Melbourne and also briefly addressing here. This is not a new concept. So almost 50 years ago, a very famous thoracic surgeon, Carmack Holmes, published a series of cases where they used bronchoscopic delivery of BCG directly into tumors to alleviate obstructed airways and allow for successful surgical resection of lung cancer. And interestingly, what they saw in the pre and post biopsies was infiltration of T cells and development of granulomas within the tumor microenvironment, suggesting that the BCG was actually inducing an immune response akin to its normal biological action. So this idea of using a bronchoscope to deliver therapy directly into tumors is indeed not new. And a variety of approaches have been investigated over the course of the last 50 years, including and especially chemotherapy, but more recently, ablative interventions using a variety of different energies, and we'll be talking very briefly about that. Immunotherapies, including cytokine delivery. This is becoming very, very interesting, especially with the ability to deliver cytokines via mRNA using lipid nanoparticles. Gene therapy directly into tumors, and I'll be talking about one such gene therapy trial today, which is now this global randomized controlled trial that I referred to. Also, oncolytic viruses. These are viruses that can replicate selectively into tumors, that can be injected directly into tumors. There's a multi-center international clinical trial of such an oncolytic virus ongoing right now. And then lastly, cellular therapy. So many of you are familiar with dendritic cell therapy or CAR T cell therapy or TIL cell therapies. Well, these are all typically delivered systemically, but there are arguments for delivering these directly into tumors. And there are trials and early trials in which these are being done through bronchoscopy, both endobronchial ultrasound and navigational bronchoscopy into target lesions. A lot will be talked about in Melbourne at WCBIP about a variety of endoscopic ablative technologies, from vapor ablation to photodynamic therapy, radiofrequency ablation, cryoablation, pulse electrical field, and microwave ablation. And my goal today is not to take you deep into these areas, but to just entice you that these are areas of active investigation around the world to see if bronchoscopic delivery of energy can completely ablate tumors akin to what we would see, for example, with SBRT or percutaneous ablation. I would also provide a word of caution, and this excellent review by Fernandez-Bussi et al. Summarizes this, which that we are in early days. So I do not believe that we have the clinical trial data to give us the information that we can replace the existing alternative therapies that have become standard of care, and that we need to develop prospective, multi-center, randomized trials ultimately to be able to evaluate these technologies to see, are they safe, are they feasible, and are they efficacious, and how do they compare to standard of care? So we'll be talking about this in several sessions in Melbourne, and I encourage you to attend these, and I'll be participating in those sessions as well and learning alongside all of you there at the conference. In terms of intratumoral delivery, I think it's important to understand why we would think about delivering a variety of compounds directly into tumors as opposed to giving them by vein or by mouth. One is you could achieve a higher local concentration to potentially increase effectiveness. Two, you could lower the systemic concentration concomitantly in reducing toxicity. You might also be able to target micrometastatic disease in lymph nodes and the potential to combine with systemic immunotherapies. The negatives would be the ability to retain your drug of interest within the tumor because there may be leakage out into the lung parenchyma or into the peripheral circulation. The tumors themselves are both heterogeneous internally as well as in all the sites where they may exist if there's widely metastatic disease. There's a risk for, as I mentioned, leakage and local regional pulmonary toxicity, specifically pneumonitis. And from an oncologic perspective, our medical oncology colleagues might be averse to this idea because it's invasive. But for us as interventional pulmonologists, it is not truly invasive because we can do this through endoscopic means without having to do surgical interventions. And the idea really in its basis is, can we inject a variety of compounds and or energies or combinations of energies and compounds into the tumor or into the lymph node that may activate, in one part, immune responses against the tumor that may generate both local and systemic immune responses that may be of benefit to the individual patient. And we've been really interested for about 25 years in my group, first at the University of Pennsylvania and now here at New York University where I work, in the use of gene delivery into tumors, now delivering genes that can activate immune active molecules within the tumor to generate these local and systemic immune responses. And going back quite some time, 25 years or so, we have been using these approaches in the pleural space in a variety of early phase clinical trials, actually maturing into a randomized global phase 3 clinical trial in mesothelioma of intrapleural delivery of a gene that activates interferon alpha within the pleural space. And we hope to be able to publish this data soon. This was presented at the International Mesothelioma Interest Group meeting in Philadelphia last year and soon to be published. But what we thought was this concept could also be applied to delivery in lung cancer. And the concept really is very simple. It's a replication incompetent adenovirus that expresses a gene called herpes simplex virus thymidine kinase. When the virus is injected directly into a tumor, either in the pleural space or in our case now, directly into the lung using bronchoscopy, it delivers the gene, and the gene is expressed within the tumors, which makes the tumors sensitive to an oral drug, valcyclovir or Valtrex, which is used for oral herpes infections. It converts the valcyclovir to a toxic metabolite, which kills tumor cells. The presence of the adenovirus itself also acts as a superantigen. And so a variety of both internal, intratumoral, as well as systemic immune responses are elicited, which leads to both local and systemic immune activity. So my group at the University of Pennsylvania studied this in what's called a window of opportunity trial several years ago, which was published in Molecular Therapy in 2020. And these were patients with early stage resectable non-small cell lung cancer who were eligible for surgical resection. They underwent a bronchoscopy for delivery of a single dose of this virus into the tumor and a single course of 2 weeks of valcyclovir, and then underwent surgery and any appropriate adjuvant therapy that was required. And what was shown is that there was significant single agent activity of just the injection of this virus directly into the tumor with 2 weeks of oral valcyclovir with no other systemic therapy prior to surgery. And that pre and post surgery, we could demonstrate that individuals developed significant both local and systemic CD8 T cell responses indicative of the induction of immune responses that could be beneficial for patients long term. And just recently, several months ago, the long-term follow-up of this patient population, the small group that underwent this window of opportunity trial, was compared to a matched control group and showed significant prolongation of survival in this setting when matched for stage X, sex, and a subtype of non-small cell lung cancer. So clearly just provocative, but suggests that this induced immune response may actually lead to long-term survival. Concomitantly, we developed what's called the LUTK02 study. This was presented at the WCBIP in 2024 in Bali and is soon to be published in a journal. This is a trial which was a single-armed but stratified phase 2A clinical trial in patients with metastatic or unresectable stage 3 non-small cell lung cancer with progressive disease or stable disease after 18 weeks of standard of care chemoimmunotherapy or immunotherapy alone. They then received 2 injections every 6 weeks of the virus directly into the tumor and 2 courses of the valcyclovir and continued with their standard of care backbone immunotherapy or chemoimmunotherapy. And this was done in concert with the foundation of the National Institutes of Health and a consortium in the United States that studies a variety of immune biomarkers in patients undergoing cancer immunotherapy clinical trials. This was a multi-site trial across the United States, 14 study sites. There you see them on the map of the United States. NYU was the lead center and the academic research organization, and for many of the sites served as the central IRB. This is the consort diagram for the study, showing a total of 76 patients who were enrolled in the study, about 51 patients who received 2 injections, 46 patients who received both 2 injections and 2 courses of valacyclovir, and also had a follow-up CT scan at 12 weeks. 5 of these were in cohort 1, which is those that entered the study with stable disease. The vast majority were in cohort 2, which is those patients who were progressing through standard of care when they entered the clinical trial. Typical baseline demographics and characteristics for a stage 3, stage 4 unresectable patient population undergoing an immunotherapy clinical trial. About 50% of these individuals had low PD-L1 expression. Most were former smokers. Most were on pembrolizumab and pemetrexed prior to enrolling into the clinical trial. What we showed was that these injections and the 2 courses of valacyclovir were extremely safe. We had less than 5% of patients had grade 3 treatment-related adverse events, and no grade 4 or higher DLTs or TRAs were seen during the course of the study. The major adverse events that were seen were consistent with the mechanism of action of the adenovirus itself, which is the expected chills and pyrexia seen after injecting a virus directly into tumors. Here is our interventional pulmonary group at NYU using linear endobronchial ultrasound to inject directly into a paramediastinal tumor. Very simple, straightforward procedure taking about 2 minutes with direct visualization and the ability using EBUS to direct the virus into different areas of the target tumor. We also were able to use robotic bronchoscopy. Here is the intuitive ion robot, again, accessing a left paramediastinal lesion that was otherwise inaccessible to endobronchial ultrasound for delivery of the virus. Again, fairly straightforward after obtaining diagnostic bronchoscopies and done on an outpatient basis within approximately 20 minutes in our interventional pulmonology suite at NYU. In terms of response rates, remember the majority of these patients had progressive disease coming into the study. So we had a few number of patients who qualified for further progression. The majority had stable disease during the course of the study, and a relatively few had evidence of partial responses entering the study. Perhaps most interesting is the change in trajectory of disease with these intratumoral injections and delivery of the prodrug orally, the valacyclovir. This led to a disease control rate in cohort 2 of 70% and 100% in cohort 1. But perhaps most importantly was the overall survival, which was seen in the combined population, cohort 1 and cohort 2, with a median overall survival of 24.5 months. And this compares extremely favorably to the best available standard of care study. For example, this paper from Reckamp et al. Published in JCO in 2022 with a combination of ramucirumab, which is a anti-angiogenesis agent, with pembrolizumab compared to docetaxel alone. And again, there's always danger compared to historical controls, but the median overall survival seen in our patient population nearly doubled that seen, certainly in the standard of care docetaxel population. And if you break it down by histologies and by just progressive disease, those with progressive disease in all histologies had a median overall survival of 21.5 months. And for those patients with non-squamous histology, 25.4 months. Again, far exceeding that of best available historical controls from well-designed phase 3 clinical trials in this patient population. What was, again, interesting about this population is that the improvements in survival were irrespective of baseline PD-L1 status, which suggested that these intratumoral injections activated PD-L1 within the tumor microenvironment. And also that we saw significant anti-tumor activity at distant sites. So when we injected into one location, we saw what are called abscopal responses, that is, responses in tumors at distant sites that otherwise had been refractory to immunotherapy prior to entering into the study. And when we looked at the total numbers of individuals in our patient population in this phase 2A clinical trial who had some evidence of an abscopal effect by volume, it was approximately 60% of individuals, which is very remarkable. When we looked at the location of injections, and this was presented, as I mentioned, in Bali at the WCBIP 2 years ago, there was a significant improvement in survival if both of the two injections were given directly into parenchymal lesions, parenchymal tumors within the lung parenchyma, as opposed to in lymph nodes in the mediastinum or hilum, and also far superior to that in peripheral metastasis, specifically into the liver, where liver metastases did not seem to generate a systemic anti-tumor immune response. So what we showed so far in the phase 2A clinical trial, which is pending publication, is that this bronchoscopic delivery of a recombinant virus in combination with an oral prodrug is extremely well tolerated with very few side effects, that abscopal responses were seen in a significant percentage of individuals, and that even in those patients with progressive disease at baseline, the median overall survival of 21.5 months compared extremely favorable with standard historical controls from the medical literature. And this was accentuated in the non-squamous population, with a durable benefit in this population of 37% alive with metastatic disease and progressive disease entering the study more than 2 years post-injection. We have some ongoing biomarker analysis, which will be the subject of a follow-up manuscript coming out, we hope, in the next 6 months or so. But most importantly, this has led to the initiation last month of the Aurora clinical trial, otherwise known as LUTKO3, which is a multi-center randomized controlled trial of this virus called aglatimagene besadenovec in combination with valcyclovir and continued pembrolizumab versus docetaxel in immunotherapy refractory stage 4 non-small cell lung cancer. So this will randomize 500 patients in a 1-to-1 basis with metastatic stage 4 non-squamous non-small cell lung cancer who've progressed through standard frontline chemoimmunotherapy and have been treated with pembrolizumab as the immunotherapy agent of choice in first line. They'll be randomized in a non-blinded fashion to either docetaxel or to the bronchoscopic delivery, either into tumors or into lymph nodes, or potentially both, with the primary endpoint being overall survival, the secondary endpoints including quality of life and safety, among others. This is the schema for the Aurora study, which is looking for sites around the world right now, and glad to take any questions regarding those listening to the call who might be interested in participating. So there are 2 bronchoscopic injections on cycle 1, prior to cycle 1, day 1, and prior to cycle 3, day 1, with 2 weeks of valcyclovir. These after each injection, these are separated by approximately 6 weeks, and then patients continue on their backbone pembrolizumab until they have evidence of progression of disease. In arm 2, the control arm will receive standard second-line docetaxel, no further immunotherapy, and no injections during the course of the study. Now, I mentioned before that there are other virus therapies that are ongoing right now globally for bronchoscopic delivery. One such study is one I will mention in a second. But the idea of oncolytic viral therapy is that there are viruses which have the capacity to selectively replicate within tumors and induce an immune response by the disruption of tumor cells, the release of a variety of disease-associated molecular pathogens, and as well as induction of responses to tumor antigens that were previously not seen by the immune system. In essence, turning a cold tumor microenvironment into a hot tumor microenvironment by the selective replication of viruses within tumors. And so there is an active trial sponsored by Johnson & Johnson right now, which is looking at what's called a multi-armed oncolytic herpes simplex virus, which is delivered either percutaneously or bronchoscopically directly into lung cancer in a variety of patients with advanced unresectable non-small cell lung cancer. And this unique virus, which was presented initially at ESMO in 2025, and the study is ongoing worldwide, has multiple therapeutic genes within it, including one for FLT3 ligand, which recruits dendritic cells to the tumor microenvironment, a CD40 agonist, which matures these dendritic cells to become effective antigen-presenting cells, IL-12, which enhances T cell effector functions, and a variety of other Th1 differentiation functions, and anti-CTLA-4. And these are all genes that are contained within the oncolytic virus, which are delivered directly to the tumor cells, in addition to the immunogenic cell death induced by the oncolytic action of the virus itself. So in the material presented at ESMO last fall, in melanoma, for example, they were able to show significant reduction in the size of pleural-based and parenchymal lesions through direct injection of this oncolytic virus, with responses both in injected regions as well as abscopal responses at distant sites. So extremely promising and actively recruiting in a variety of settings right now. Here is the schema. It's combined with Johnson & Johnson's own anti-PD-1 monoclonal antibody in the schema that you can see. The injections are given every 2 weeks, percutaneously or bronchoscopically, up to 8 doses, and recruiting in these actively recruiting cohorts, second line plus metastatic disease with low PD-L1, first line metastatic disease with high PD-L1, and metastatic disease who are receiving immune checkpoint inhibitor as part of their ongoing standard of care. So what I've told you so far is the exciting finding that viral immunotherapy has demonstrated safety, feasibility, immune responses, and preliminary evidence of survival impact, that there's a first ever global randomized controlled trial of intratumoral therapy delivered by bronchoscopy, a landmark for the field, which may change the way that interventional pulmonologists act in terms of the treatment of advanced lung cancer, getting us actively involved, not just in palliation and diagnosis and staging, but in therapy. That oncolytic viral therapy holds promise, has been approved in melanoma, and is on its way for further evaluation in non-small cell lung cancer, and that these will both rely upon combinations of standard of care agents for efficacy. So we'll be part of incorporating into multidisciplinary therapy for non-small cell lung cancer and other malignancies going forward in the future. So I just want to thank our working group, as well as all those working on these clinical trials in the United States, around the world, and most importantly, the study patients and their families. I'm excited to talk about these and other studies of intratumoral therapy in Melbourne with all of you, and happy to take any questions that you might have.
Thank you so much, Dr. Sterman. That was a great presentation. We really appreciate your time and nice, excellent review. This is an exciting moment, as you said, is just setting up the stage for the pulmonologists across the globe to not just contribute to the diagnosis and the staging of lung cancer, actually be part of the treatment. I think we are looking forward for the close future to see how it's going to pan out. And of course, exciting to hear more at the Congress from you and other colleagues in this nice topic. Appreciate your talk. In the meantime, I would like to thank my colleague from the World Association of Bronchology and Interventional Pulmonary to give the opportunity, especially Mr. Mendoza and Dr. Denai Kimasuvan, who also organized this presentation along with me. I appreciate that. And now we're going to move on to the next speaker. I would like to ask Dr. Ing. Alvin Ing is the expert and leader interventional pulmonologist in Australia, and he is the head of the clinical program at Macquarie University in Australia. And we ask you to please present your talk, which will be about advanced studies and the therapies in emphysema and chronic bronchitis. Please, Alvin.
Thank you very much for the introduction, Ali, and thank you, Dan and Nick, for your talks as well. Appreciate that. As a local and as the WCBIP is in Melbourne, let me encourage everyone to come to Melbourne. It's as you've heard from Nick and Dan as well, there's promising and really exciting talks and lots of advances in IP. But not only that, Melbourne's a wonderful city. The food scene, the theatre scene, the live music scene is great if you're interested in that. And it's only a short hop to Tasmania, where there's wonderful walking trails, wonderful whiskey, and there's also the south coast of Victoria. So for anybody wanting to take a few weeks off to savor Victoria and Tasmania in Australia, this is an ideal opportunity to do so. So let me try and encourage you to come down, not just for the academic stimulus, but also maybe to boost our economy as well. So hope to see you all there in Melbourne in December. I'm going to talk about therapies for advanced emphysema. I'm not going to talk about chronic bronchitis therapies, which we've been involved in. You'll have to come to Melbourne to hear that, given the short time frame that I've got today. So let me just show my disclosures. My disclosures are predominantly that I'm a principal investigator with a lot of the studies that I'll talk to you about today. Basically, some of these are sponsored studies, some of these are investigator-led, and I'll try and walk you briefly through some of these. I'd like to give thanks, as Dan did, to his team that allows all our trials to happen, especially our clinical trials unit and all our co-investigators, some of which you'll see pictured here. There's reasonably well-established guidelines for the interventional therapy for COPD, lung volume reduction surgery, which started in the 90s in the States, bullectomy, transplantation. But I'm going to talk predominantly about the last two on this slide, bronchoscopic interventions, and also bronchoscopic interventions under study. The latest GOLD guidelines has this slide, which basically separates COPD into heterogeneous emphysema versus homogeneous emphysema, and then whether they've got complete fissures or incomplete fissures. But the evidence suggests that we can more finely sort of choose our therapy based on some of the evidence that are available, and I'm going to try to walk you through that. When patients are referred to any centre that looks at lung volume reduction, most centres will try to analyse the CT DICOMs for both emphysema destruction scores as well as the fissures. And this is a typical analysis of the DICOMs that we get from our patients. You can see there that the right upper lobe is most destroyed. There's a complete fissure on the right. There's a complete fissure on the left. But the left upper lobe is not as destroyed as the right upper lobe and right middle lobe. So you would target right upper lobe and right middle lobe with valves, and that's a fairly easy decision. And the whole point of doing lung volume reduction for COPD is to get volume loss. So this is a model that we did where we put endobronchial valves in the left upper lobe to basically show that the targeted volume loss that you get, which is what you're aiming for, and the sort of improved ventilation into the non-targeted lobe. And I'm not going to go through the many, many studies that have been done, including good RCTs for the valves, including the Zephyr valve as well as the spiration valve. They're listed here. There's more than this, but there's good evidence, which is why there's recommendation in the GOLD guidelines now for valves for patients with heterogeneous emphysema with complete fissures, and to a lesser extent, homogeneous emphysema with complete fissures. And the whole point of doing volume loss is that it improves prognosis, it improves symptoms, it improves lung function, and it improves mortality. But it's all dependent on volume loss. Without volume loss, you don't see these gains. This is a chart that Felix Hirth published in 2019, and I still think it's a reasonable guide to help you decide what you do with your patients with emphysema based on fissure analysis. I think if you look at the left-hand side, if they've got complete fissures, and particularly if the Chartis is negative, then there's no question that endobronchial valves should be your first choice. That's where the most evidence is. There's some evidence for coils, but most of the evidence in that group is for valves. So I'm not going to talk about that because that's well established, and I don't think there's a lot of argument regarding that. What I want to talk about is patients with incomplete fissures. So this is a patient from 6 or 7 years ago who has incomplete fissures in the left, incomplete right oblique fissure, and a reasonably complete horizontal fissure. But in these patients with incomplete fissures, particularly if they're Chartis negative, Chartis positive, sorry, that have got collateral ventilation, then endobronchial valves are not going to be effective, and you're not going to get volume loss because of the collateral ventilation. So what do we do? So about 7 years ago, we looked at this problem because more than half the patients presenting to us for lung volume reduction had incomplete fissures. So they're not suitable for endobronchial valves. So what alternative therapies was there? So this is a case report that our group published in 2020, looking at a proof of concept using polymer sealant to seal the fissure defects before using endobronchial valves. And you can see where the fissure defects are on the analysis of the DICOMs. That's where the red is. And using the using the fissure defects, you can actually map which segments go to that defect. And in this initial presentation and proof of concept patient, we can see that it was mapped to LB4 and LB5. And then we placed polymer sealant into that to try to reverse collateral ventilation. This is the initial charges that we did, which it's not a perfect trace, but it's clear evidence of collateral ventilation in the left upper lobe. We then instilled 10 mils of polymer sealant into LB4 and LB5. And it's done with a balloon catheter. And this is the actual charges of the patient following endobronchial sealant deployment into LB4 and LB5, which shows no collateral ventilation. We placed the valves in the left upper lobe and lingular, and we got successful volume loss and target atelectasis in the left upper lobe. So on the basis of that, we did a parallel control group trial, which we published in 2022, and that looked at a population of 28 patients, 14 controls, 14 patients who had collateral ventilation, and we all targeted the left upper lobe, and we mapped the fissure defect to the segments. In this patient here, you can see that it's mapped just to one segment, LB5. In this patient here, it's mapped to 3 segments, LB12, LB4, and LB5. And we used the equivalent of 10 mils of polymer sealant to target wherever the mapping told us that it would subtend the fissure defect. And we found basically that both groups, both the control groups, those that had valves that had no collateral ventilation, and those that had collateral ventilation treated with the polymer sealant and then valves, had significant improvements across all parameters, with the only difference between the two groups being FEV1, where the improvement in FEV1 was slightly better in our control group. But we had significant improvements across all parameters. And this is the typical sort of radiology that you see in our patients. So we're targeting the left upper lobe here. The second film shows the polymer sealant into LB4, LB5 the day after the procedure. The third chest X-ray shows what the X-ray looks like 1 month after procedure, and the last film on the right shows what the X-ray looks like after valves are inserted. So there is significant areas of inflammation, which is the reason why you get targeted volume loss in those segments, but it's also why you get fissural closure. On the basis of that sort of small study, there has been a multi-center, multinational study called a CONVERT trial, the data of which was presented in 2024, and the results should be published imminently, and hopefully we can give you the final results at Melbourne in December. So CONVERT trial was presented at ERS in 2024, 101 subjects enrolled, 65 years was the average age. FEV1, as you expect, 30%, RV, as you expect, greater than 175%. Fissures were incomplete, and 73% of our patients successfully converted, and the mean targeted volume loss was about 350 mils. So we'll be presenting more data on follow-up at 6 months and 12 months, and also some CT changes, but hopefully we'll be able to present the final data later this year. On the basis of that completed study, there is now a second multinational, multi-center trial, CONVERT-2. You'll see the sites enrolling there, and hopefully we can conclude this study in the next 12 to 18 months, and that will provide further evidence, hopefully, for an effective treatment for patients with incomplete fissures that was not previously available. So we've talked about valves, which is the left-sided arm. We've talked a bit about patients with incomplete fissures with fissural defects between 80 and 95%, which is what the CONVERT-1 and CONVERT-2 studies basically targeted. So what about the third group, those who have large fissure defects with significant incomplete fissures, what alternatives have we developed there? So this is a patient where the convert study would not be appropriate, given that the fissure defects on the left are greater than the 20%, so the fissures are less than 80% complete. And there's large fissure defects, as you can see on the diagrams on the right, where the red represents the fissure defects. So thermal vapor ablation has been around now for about 15 years. And we did do a trial of that in Australia, but let me just summarize some of the data. So it is segmental therapy. It's not lobar therapy like valves or like polymer sealant and valves. It's segmental therapy. And we utilize a balloon to obstruct the targeted airway and then deliver steam into the appropriate segment. The amount of steam is determined by an algorithm which looks at the massive viable lung tissue, the volume, and then the energy is controlled by time. This is a publication now 10 years ago, which a small study, but it was controlled. And there's not a lot of control studies in this area. 45 patients, 24 controls, looking at 6 and 12-month follow-up with significant improvement in FEV1 and SGRQ, which was statistically and clinically relevant. This was the step-up protocol. In other words, they treated a couple of segments on one lung, and then after a period of time, they treated the other appropriate segments in the contralateral lung. It's not lobar therapy, it's segmental therapy. And there's lots of attractions to segmental therapy, because if you look at right upper lobe here, RB1, RB2, RB3, and you look at disease severity based on destruction scores at minus 950 Hounsfield unit, which is the top line, you can see that RB1 and RB3 are quite destroyed, but RB2 isn't. So there's not a lot of sense in doing lobar therapy and collapsing and targeting RB2, given that there's not a lot of destruction there. It would make more sense targeting the most destroyed segments, which in this patient would be RB1, RB3, and perhaps RB5 or even LB9. So that's a sort of algorithm and the sort of thinking behind segmental therapy. There's not a lot of published data on thermal vapor ablation apart from the step-up studies. There's lots of case series. This is the most recent case series that was published from Israel. It was published last year. And they had 50 patients. Median follow-up was 19 months. 2-year follow-up for 20 patients. So again, one of the sort of shortfalls of a lot of the ELVR studies is follow-up. Some for 6 months, some for 12 months. Not a lot go beyond 2 years, which is unfortunate. So this study, which was non-controlled, showed significant improvement in FEV1, FVC at 12 months, but not for 6-minute walk test, and follow up to 24 months. The effective FEV1 improvement dropped to less than statistically significant levels, but statistically significant levels were still maintained with FVC. So as you expect, and this is the data from the surgical data as well, is that there is the decline in function, lung function over time, as you would expect for someone with severe or very severe COPD. The adverse events in this study, significant, 10% had pneumonia. There was a 14% overall mortality with a 6% procedural associated mortality. So there is significant mortality with BDVA, and that has come from respiratory failure and also has come from significant bleeding, which is why patients going for BDVA have all anticoagulants and antiplatelet agents stopped for 6 weeks before and after the procedure. We did 13 patients in our case series, which we reported. Significant improvement across most parameters, FEV1, residual volume, SGRQ. But there are complications. So these are 3 CT scans of 3 of our patients. You can see some of the changes you get with thermal vapor ablation. The heat causes inflammation, as you would expect, which causes volume loss. But that can also lead to complications, including pneumonitis, which is not infective, as well as hemoptysis if you get infarction. This is a patient that had significant bleed in one of our patients. And you can see the reason why there's significant inflammation and we think infarction of the treated lung. I'll just mention this. There is another technology similar to bronchoscopic vapor ablation, which is thermal liquid ablation. So instead of steam, it's 95 degrees saline. There are some advantages, I think, of using saline and rather than steam because of its reach. There's an ongoing study at the moment, but this is again segmental heat therapy. This is an example of someone that we would use given the incomplete fissures. And it's not only segmental therapy, we're actually doing this subsegmental therapy. And we're targeting subsegments. And this is a example of a treatment plan. We map which segments that we treat quite carefully because you don't want to treat the wrong segment. And in this study, which is the reduced study, 33 patients were recruited in Australia across 3 centres. I can't share any of that data with you at the moment, but hopefully we can present some of that data in Melbourne. So segmental therapies with either steam or thermal liquid ablation are targeting patients with severe and very severe COPD with similar parameters to endobronchial valve therapy, FEV1 20 to 50% hyperinflation. But who should we target for this therapy if they're not suitable for valves? Basically, fissures less than 80%. Patients that have nickel allergy, given that valves are nickel titanium. Patients that have segmental heterogeneity rather than lobar heterogeneity. But we also have to be conscious of safety factors, including a significant risk of bleeding. The other segmental therapy that's been published recently, was published last year, is airway scaffolding. And this is the Aprio Health Breathe 1 and Breathe 2 studies. And this was published last year in the Blue Journal. And it uses what has been termed scaffolding. They're nitinol coils, but they're not like the coils that have been published previously. They are more scaffolding, and what they do is they help keep distal airways open and therefore allow trapped gas to escape, which is the theory behind this therapy. It's delivered endoscopically, and again, we're targeting segments. So we get minus 950 destruction scores. We get a sense of how long the airways is, so we can target the right length scaffold for the right airway. And this is how we deliver it. This is the delivery catheter, and you can see that we deliver generally 3 scaffolds to the worst 3 segments on one lung at one procedure, and 2 or 3 scaffolds to the worst segments in the other lung at a second procedure. This is what the scaffolds look like endoscopically. And you can actually pass an ultra-thin scope, an MP190, through the scaffolding, and you can actually go all the way to scaffolding and actually see the lung parenchyma. It's really quite an interesting sight, but the scaffolding allows us to see the lung parenchyma safely. And the reason for doing that was to ensure during the study that there was no obstruction, that there was no kinking, and especially that there was no granulation tissue. And surprisingly, although I thought we would see granulation tissue, as you can sometimes see with nitinol valves, we didn't see any in any of our patients that we did follow-up bronchoscopies on. This is the waterfall plot of the results, significant improvements in FEV1 at 6 months, significant improvement in RV, reduction in gas trapping, but no change in FVC, and also significant change in SCRQ, CAT score, as well as 6-minute walk test. 12 months data weren't presented, and hopefully we can present further data at subsequent conferences and hopefully in Melbourne as well. Not without significant side effects. So about 10% patients have pneumonia, about 5% had COPD exacerbations, but interestingly, no patients had any pneumothorax. And pneumothorax is one of the significant concerns that we had at the start of the study, but this did not eventuate in our 55 to 60 or so patients. So on the back of that trial, there is now again, a multinational, multi-center trial called a Breathe 3 trial, which is looking at 250 patients. It's randomized 2-to-1 scaffold to control group. And the protocol has the control group can cross over at 12 months, and there's a planned follow-up for 3 years. So that again will be interesting to see. Recruitment is underway, and hopefully we'll see results in a few years. And again, one of the few randomized controlled trials that we see in this area. The last thing I'll talk about in the last few minutes is something that we've been doing at our hospital. It's been something that we've been thinking about for a number of years, and it eventually eventuated a month or so ago. And this is what we the theory and the basis of what we did is centered on an observation that we made during the CONVERT-2 trial. And what we saw is that when we injected polymer sealant into the airways to try to reverse collateral ventilation, we actually saw airways inflammation and volume loss even before we put valves in, and patients reported significant improvements in their symptoms even before the valves went in. And on the left is an X-ray of a patient that just had some polymer sealant placed into RB6 and RB8, just 20 mils, and you can see the significant volume loss in the right lung. And on the right is another X-ray of another patient that had 30 mils of the polymer sealant injected into the lower lobe, and again significant volume loss with significant improvement in symptoms. So based on these anecdotal observations, we have started an investigator-led trial. It's a parallel group control study with severe and very severe COPD patients, with the control arm being those that get valves normally, fissure completeness greater than 95%, and the treatment group being those that have fissure completeness less than 80%. And we used up to 40 mils of polymer sealant injected into the most emphysematous segments over 2 procedures. Again, we're doing segmental therapy, not lobar therapy. This is our first patient where we targeted LB1, LB2, and LB3 in one sitting, and we'll be targeting RB6 in the second sitting. But they're potential treatments, and you can see why, again, segmental therapy is something that's very attractive compared to lobar therapy, given the differential segmental destruction in lobes. We're also looking at segmental perfusion and segmental ventilation to determine whether or not that is a signal for trying to predict who will respond. And this is an example of a CT scan of someone that has the polymer sealant, and you can understand why there's volume loss there with the inflammation that's there. It's a N of 34 for statistical significance, 12-month follow-up, and we're looking at segmental volume changes, segmental VQs, as well as all the usual parameters. And the reason why it's attractive to use this product is because it already has regulatory approval in Australia. So I'm going to end my talk there and basically use this slide to summarize our current thinking of where ELVR is in severe COPD. Complete fissures, heterogeneous or homogeneous disease, I think the evidence is clear for valves. The guidelines say also look at thermal vapor ablation as well as coils, but the evidence for that is a lot slimmer than valves, and I think it'd be hard-pressed to go beyond recommending valves in that group. For those that have incomplete fissures, 80 to 95%, I think the sealant plus valve option is really attractive. We don't have final results on those yet, but the CONVERT-2 trial hopefully will give us some answers. And in those that have less than 80% complete fissures, the evidence is still fairly thin. Scaffold holds promise. There is evidence of vapor ablation, although it does have significant adverse reactions. And we're really hoping that the polymer sealant segmental therapy alone without valves bears promise. I think initial data suggests that there is initial improvement. The question is how long does it last for and whether it's prolonged. So interesting things over the next few years that will follow up in the field of ELVR and COPD. So thank you very much for listening to me.
Thank you so much, Dr. Ing, and it was a great review. I really appreciate you tackled almost all the trials. It's good to hear different trials and the outcome. And as we know, the COPD and the huge burden around the globe, how we can tackle that, and then to see what's coming out, will pan out. Appreciate. I will encourage the audience also to add their question here. While we have a few, we have only about 10 minutes to raise some of the questions, and I will appreciate the speakers if they can. Maybe we can start with the first question. Now we just hot on the topic on COPD. Maybe Alvin, you can answer this question that raised that apparently for the last few years we have seen that some surgical approaches have been a little bit out of the favor, but we see more results coming out with, especially with the new surgical techniques that become less invasive, using a lot of robotic technology, and looking into that. What do you feel? Is there any change in practice recently? We can probably have multidisciplinary teams in institutions to include the surgeons and combine a different aspect of surgical to bronchoscopic. And what do you see in the future will be what roles for each team and how we can tackle that? Is there any also new update about maybe better outcomes from some cases that might be a better candidate for surgery than bronchoscopy?
I think a interventional pulmonology multidisciplinary team approach is actually vital. And I think that for selected cases, I think surgery is absolutely the right answer. For patients with paraseptal disease, I think there's no doubt that a surgical approach is appropriate. There's good evidence that valves and other forms of therapy is going to be ineffective in paraseptal disease. The other time we often involve surgeons is when patients have significant emphysema, but they have a nodule or proven lung cancer, and sometimes you can kill two birds with one stone. Sometimes you can do either a segmentectomy or a lobectomy in the most diseased lungs if there's also underlying neoplasm there. So absolutely, we involve our surgeons. There's also a study which is sponsored, I think, by Pulmonx from Gavin Wright in Victoria, where he's actually looking at patients with incomplete fissures, and he's actually stapling the fissures and then putting valves in. So the question is obviously, why wouldn't you just take the lobe out while you're in there? And the answer is that there seems to be less morbidity and less mortality by closing the fissures with a staple and then putting valves in. So yes, there are developments and innovations in the field, and absolutely, I think we should involve our surgeons.
Yeah, awesome. It just tell us how much we still need to learn and practice, and room for improvement. Thank you so much. My next question will be addressed to Dr. Sterman. Dr. Sterman, thanks you for your talk. We always learn from you, all this talk that you have. The question will become, how soon do you feel in the field of interventional pulmonology that we can have some word or maybe participate in the things that our colleague in surgery and oncology will do, kind of, the therapies through the bronchoscopy become like a standard of the care, either in different stage of the disease. How soon you see in the future in your perspective?
Well, I think you remember that bronchoscopic therapies for endoluminal cancer are standard of care, right? So, and our oncology and surgery colleagues rely upon us to alleviate central airway obstruction and also treat malignant pleural effusion. So it is not that great a leap to say that some of the technologies that we've used for endoluminal disease may be beneficial for parenchymal malignancy in the future. I think the key really is a well-designed clinical trial, and I think that this is important for the field. What you've heard from Dr. Ing and from Dr. Maskell is that in bronchoscopic treatment of COPD in pleural disease, we have extremely well-designed, well-constructed, analyzed clinical trials that provide us with data that we can rely upon. We need to do the same thing as these bronchoscopic therapies come out in vogue and not become overexcited by the ability of these technologies to be delivered to tumors. We need to analyze them and compare them against the best standard of care. So in terms of the timing, I don't know what the timing will be in terms of when they're going to be well incorporated. I do think there are some circumstances in which you can imagine that there are low bars for incorporation of these therapies. We're talking about energy specifically, Ali. I think we're talking about patients with significant interstitial lung disease who have malignancy that's diagnosed and is local within those regions. And then potentially, harking back to what Professor Ing said, patients with severe emphysema who aren't candidates for surgical resection. There may be bronchoscopic therapies for the cancers that originate within these emphysematous regions that may be of benefit for patients who aren't good candidates for SBRT or percutaneous ablation. So to me, those are the areas in which we're going to have the earliest adoption, but still we need to conduct well-designed, randomized, multi-center clinical trials to be able to analyze these against the best available standard of care.
Okay, awesome. Thank you for your comprehensive answer. Appreciate that. I mean, there's another question, maybe we should have probably addressed to Dr. Maskell, but I think because of the late timing, he left. But I will bring this up. Hopefully, we can get the answer from any other speakers or maybe in the future, is that the success rate of the malignant pleural effusion for pleural disease. So we hear in the past from different trials, like when the IPC plus or now with tactics is around like 50 something, less than 60%. But in the past, we were expecting with rapid pleural disease, like in TAPS trial, which should have been like around 80%. What is the expectation should be from the pulmonologists across the globe? So if anyone just pitch in, I know maybe Nick is not there, but we can
Alvin?
probably.
I don't. My good colleague, Professor Tajai Sagai, is our pleural guy, so I won't speak for him. But I don't think I can give you an accurate answer there, unfortunately, Ali.
Yeah. So hopefully we will hear more. There's many reasons for audience to come to Melbourne and then hear from different trials and more in the future, that a lot of studies that will be designed, some of them will be presented as the outcome. There's a quick question here from the audience. Alvin, is somebody asked what is the difference between heterogeneous versus homogeneous emphysema? Do you want to just explain to the audience that maybe that become like a big question for them?
All right. So heterogeneous emphysema is when there's significant differential in the destruction scores of the lobe that you want to target versus the lobe you don't want to target. And there's varying numbers quoted in literature, but we look at a differential between 12 to 15% destruction scores. The evidence is that if you've got complete fissures and heterogeneous disease, then you'll do better than homogeneous disease. But homogeneous disease still improves after ELVR, particularly if there's gas trapping. But we often wonder which lobes should we target if the destruction scores are both the same. And there's some good data now looking at differential ventilation perfusion and looking at ventilation perfusion of each of the targeted lobe. And if both lobes are the same and they're hyperinflated, say their RV's 250%, then we know the deflating will help. And then you would target the lobe with the reverse ventilation, reverse perfusion. And I think that there's reasonably good evidence now that that's something that is effective and backed by evidence.
Thank you so much. Appreciate that. I think we are getting close to the end of session. We can probably pass the questions to the speakers through their private lines. At the end of the session, I would like to thank all the audience who joined this webinar across the globe with different timing. I know it might be difficult for people around the globe, but appreciate our greatest speakers, Dr. Sterman, Dr. Ing, Dr. Maskell, to joining us. We really enjoyed your talk and presentation. We look forward to hear more from you and other colleagues in Melbourne to listen and participate in the talks and the speeches in Melbourne soon. If there's any special note anybody wants from the panels, have any
I want to encourage everyone online to, if you haven't made your plans to come to Melbourne, it's one of the most beautiful cities I've ever been to, and a lot of fun. And I think that you'll enjoy the conference. If you've never been to a World Congress of Bronchology and Interventional Pulmonology, it's incredibly collegial. We have a lot of fun as an organization, and we learn from each other. So I would encourage you to come. For those of you from the Northern Hemisphere, a chance to extend your summer and have some good weather. So come join us all in Melbourne in December.
You're an honorary Australian, Dan. That's well said.
That's awesome. I think this is, to me personally, has been going to World Congress has been a great experience. Learning and seeing different perspectives from colleagues across the globe. That's been great. I encourage people, to join that. With that, we'll conclude the session. Appreciate it, and I wish everybody have a good time in their time zone.
Thank you.
Thank you for hosting. Thank you.
Thank
you, everybody.